bangun. Hello.
Hello.
Hey, can you hear me?
Mhm.
Yep.
Good evening and welcome to First Say Chats by Dr. G. I'm Dr. Adana Grandison, a physician in Barbados, and your hostess for this evening. First Say Chats by Dr. G is a live podcast that provides listeners with a unique opportunity to not only hear complicated medical conditions explained, but also clarify any misunderstandings you may have about that condition. After all, a medically aware and educated patient is an empowered patient. And this evening, our episode is entitled, What's Wrong with My Breasts? And our guest this evening is Dr. Alex Doyle. Dr. Alex Doyle is the Chief Resident and Senior Registrar at the Queen Elizabeth Hospital in the Department of Surgery. Dr. Doyle currently works under the services of Dr. Bernstein and has been a candidate for the DM program at Cave Hill campus. Good evening and welcome, Dr. Doyle. How are you doing?
Hi, good evening. I'm well. How are you?
I'm fine, thank you. Dr. Doyle, I thought that this, although we are outside of the Breast Cancer Awareness Month, I thought it was important to continue to emphasize taking care of your breast. And I know quite often persons tend to get a bit concerned if they know changes of the breast. So I really wanted to start this evening's conversation, first of all, outlining the role of the breast and what is the normal breast, and in your breast examination, what we should really be looking for.
Okay. Thanks for the opportunity again to share on this important topic. Like you
Thank you.
said, we just finished Breast Cancer Awareness Month, and I think a lot of emphasis has been placed on breast cancer throughout the years. And that really only encompasses one part of the pathology of the breast. There are other pathologies that can manifest within the breast. These would be, outside of cancer, benign conditions.
Right.
So, at a basic level, the breast is really a modified sweat gland, and it
Mm-hmm.
has been modified for us, for humans, really, and in other animals as well, to produce milk. And that
Right.
is its main function. Of course, as we are human beings, we know that the breast also plays a psychosocial role as well. It
Absolutely.
has a lot to do with the way that patients and particularly women feel and make them feel feminine. There
Right.
is a sexual role as well.
Mm-hmm.
So, outside of just producing milk, there are other roles that the breast does play within society.
Great. And can you take us straight into how one would examine the breast at home and when is a good time to examine the breast before we go into the different types of breast pathology?
Right. So, in terms of examining the breast, I think one of the terms that you might have heard within the last month would have been being breast aware, right? And that basically, at its most basic level, is a term meaning you should know how your normal breast feels. A lot of the time, pathology is actually picked up by the patient initially when they are palpating their breast. So if you have a basic knowledge of the normal texture, architecture, and feel of your breast, then it is a lot easier for you to actually identify when something may be abnormal.
Mm-hmm.
Now, it is usually probably better to do this outside of your menses when you're not having the different hormonal changes. But even through menses, and when for some persons may actually complain of breast pain or have different complaints related to menses, it's also still a good idea to see how normally their breasts may change throughout their menstrual cycle so that they can get a normal feel for the breast and know what may be normal and more importantly what may be abnormal, because then that is the majority of the time how patients then are going to present to their physician for further evaluation.
Right.
So I would say both the patient and even sometimes the partner, because a lot of the times it is that the partner may actually notice that there is a pathology within the breast, something that was not there before.
Okay, okay. So what are we looking at? Walk us through from simply even just looking at the breast to start off.
Right. Right. So when we're looking at the breast, and this can be in the mirror just before you take a shower or even after the shower, we're looking to see whether there's a normal contour of the breast. Um, and you would know growing up, meaning the patient may know growing up, if one breast is bigger than the other, because a lot of the times there may be asymmetry in terms of the size of the breast. But if you then see that there's an abnormal contour to the breast, meaning either you may see some dimpling that wasn't present there before, or a protrusion coming from the breast that you didn't notice before. That is
Mm-hmm.
something that can alert you that there might be some underlying pathology within the breast itself. And then, furthermore, specifically looking at the nipple. So, and it may be a normal variant that some persons may have a nipple that is what we call retracted. Um,
Right,
if that has been your normal, then that is normal for you. If, however, your nipple has never been retracted, meaning that there's some type of dimpling or distortion to the nipple and around the nipple itself, the darkened area around the nipple, which we call the nipple areola complex, then that can be an indication as well that there may be some pathology, and then you should probably seek some medical attention to identify it. The then further going into feeling the breast itself in terms of the breast, whether there are any abnormal masses or lumps that may arise. Now, like I said, there's certain persons and certain conditions. They may have cyclical changes within the breast itself, where they may have some cyst forming throughout their menstrual cycle that may go up and come down. And being breast aware will help you to recognize whether this is something that is normal for you or abnormal. So if you're
mm,
going to feel a mass, whether it be hard or soft, whether it is painful or not, and then if there are any associated changes surrounding this mass that you may be feeling, whether it's red, erythematous, if it's painful to touch, and then associated things such as discharge from the nipple.
mm-hmm.
So, if this discharge is spontaneous, or rather it is evoked meaning that you have to press the breast for it to actually produce a discharge, or whether it's spontaneous, and a lot of the times spontaneous may mean that it's just produced, or the patient may just notice it actually staying in the bra or their clothes if you're not wearing a bra. So
Right.
those are some of the things that you're looking for um, when you're trying to be breast aware.
Right. So I like the fact that you mentioned, first of all, taking a general look at the breast, not even going into
Yeah.
touching or feeling yet, but actually taking a look at the breast and noting if you've seen any dimpling or any changes, certainly any skin color changes as well, which I think sometimes a lot of persons overlook. I'm glad that you actually mentioned that. And then also about the inversion of the nipple. So if you've noticed that your breast has changed, your nipple, sorry, has changed from being everted to an inverted nipple or retracted nipple, as you called it, then certainly it is a reason for you to have a further examination. And then certainly palpating the breast. I like the fact that you also commented about using the breast examination not just outside of the time of the menses, where sometimes the female or male may not, well, males don't have a menstrual cycle, but the females outside of the menses, so that they're not sensitive in the breast, but certainly even sometimes during the menstrual cycle, so that they can appreciate changes if they are noticing that they're having changes during that time. um, I wanted to go on to speak about some of the common things that scare women, because you quite nicely stated at the very beginning that the majority of times, even if you have felt something in your breast, although we have focused over the last month about breast cancer, there are other conditions, benign conditions. So, can you walk us through some of those conditions, starting from in the very young female and then going all the way through past menopause, some of the common ones? And then, certainly, let's talk about male breast.
Sure,
Mm-hmm.
no problem. So, uh, to make a distinction in general terms, when we're talking about pathology of the breast, we divide them into two broad categories. And that would be either benign, meaning non cancerous, or malignant. And that would be your breast cancer. And then there are different other variants of other malignant, potentially malignant pathology within the breast. So I'm going to talk about the benign and try to concentrate more for this evening on the benign category. So one of the most common pathologies that we will see, especially coming through the hospital throughout the teenage and then going into your 20s and 30s, is the breast abscess. That is usually one of the most common reasons that persons will actually go and present to their general practitioner. In this scenario, there's usually a new swelling within the breast, and this is usually going to be associated with the typical signs of inflammation. So you're going to see some redness. You may not necessarily see redness in dark-skinned individuals. There may be some tenderness, and depending on the duration of the symptoms, you may actually see a discharge coming from this mass. And this is usually inflammation, or what we colloquially call pus. Right? It is normal that this can occur in lactating females. So there is a small abrasion that is sustained while the infant may be breastfeeding. The skin, being one of the barriers to infection, is broken, and then you get a bacteria entering through this tear in the skin and causing an infection. In this scenario, usually the patients will have some type of discharge, and like I said, the other symptoms and signs that I had outlined before. Treatment can range from just antibiotics and aspiration, and if that fails, then they may need actual formal incision and drainage.
And when you say aspiration, exactly what are we talking about?
Right. So in the past, a lot of the times we would just go straight to incision and drainage, and that honestly can cause some poor cosmetic results in terms of having scars on the breast just to drain some inflammation. So what normally is the practice now, and what we're trying to do more and more, is that even with or without ultrasound guidance, because you may need ultrasound guidance to try to identify specifically where the loculation of inflammation or pus is. And then either under ultrasound guidance, you can place a needle within the cavity and withdraw, which is what we would define as aspirate, any of the pus that was within the abscess cavity. We can then send that for testing to see what organism is actually growing, so that we can culture and give appropriate antibiotics. But a lot of the times, it's going to be your gram-positive organisms, and simple antibiotic coverage that will be available to the general practitioner would be something that is usually advised. So your cephalosporins or even a penicillin. Specifically for those persons who are lactating.
Lactating, that's safe for the baby.
Yes, so antibiotics that is safe for the baby. We do encourage persons to still lactate during this time period. If, however, the antibiotic choice that is necessary is not safe for the baby, then you will have to hold on breastfeeding during that time period. And there is a spectrum, so I should say that there is mastitis, which can then progress to an abscess as well. So mastitis is just simple inflammation without abscess formation, while the breast abscess then is something that may need aspiration. So that is one of the more common pathologies that we will see. Outside of the lactating female, who may then have a breast abscess, usually there is some abrasion or some trauma to the area again, which may have caused a break in the skin barrier. And then this leads to a portal of entry for the organism to enter the body and then cause infection. There are some entities where there is no known underlying cause, But then these can be associated with things like tobacco smoking.
Right.
It's not.
Okay.
And then there also is the other something that may be more common that I recognize, nipple piercings. So
Right.
persons that have nipple piercings, and then those can get affected as well.
Absolutely. Now, quite often, a lot of young females will come to the office, or when I was at the hospital, would present to clinic and would tell you, "Doc, I'm feeling a lump in my breast, and it sort of feels as if it's like moving around, but I'm really
Right.
concerned about it." Can you give us some more insight on possibly what something like that can be?
Right. So this is one of the other more common conditions that we see, and especially in the teenage and those going into their 20s and a little bit more in their 30s. So one of the more common conditions is something called a fibroadenoma.
Right.
Some people may call it a breast mouse. Um, so, what this condition actually is a mass which arises from two of the major elements within the breast itself. No need to get too deep into the pathology, but it is a benign condition which the total etiology is not really understood. They do believe that it has some hormonal components to it because it can on occasion increase in size
Right.
related to your menses. So it's usually a benign condition, but patients obviously will present because they're feeling this lump in their breast and they're concerned about it. And throughout all of these different pathologies, that is the one thing that you have to keep in mind as a physician, that when a patient is coming to you with any breast pathology, foremost in their mind, even if they don't mention it, is their consideration: is this breast cancer or not? And that
Right.
is one of the things that you have to try to allay their fears. So, in terms of a fibroadenoma, that is a benign condition. And usually, if there are no symptoms, meaning that there's no pain associated with the lesion itself, if there is no great increase in size of the mass itself, and if there is no significant family history of any malignant breast disease, these are lesions that can usually be monitored. Now, you will have the patient that, regardless of how you may try to reassure them, they want the lesion out. It's either it affects their psyche knowing that there's a mass there, or they're just so worried about the lesion that they want it out.
Right.
And outside of these other criteria that I mentioned, obviously, if a patient wants out the lump, those are some things that can be excised. There is a role potentially for ultrasound examination of these lesions. So ultrasound can look to see whether it is a rounded structure, whether there's any septations within it, whether there's any calcifications within the lesion itself. And it can also help to guide in terms of biopsying the lesion. And that is another way that we can try to allay some patients' fears by actually getting a biopsy of the lesion so that we can show that it is indeed just a fibroadenoma. I
So,
should mention
go ahead.
before going on, there
Hmm.
is an entity where we have something called a giant fibroadenoma. So, where these lesions can grow to greater than 5 centimeters, that would raise a concern because then your differentials then have to be a lot broader in terms of what you may be thinking is going on within the breast. And there is the potential for a sarcomatous change within the breast and something called a phyllodes tumor. It
Right.
is a very rare lesion, but we do see it not so uncommonly within patients, and that is the one thing that you need to consider when you're seeing patients with a fibroadenoma, because it does develop from the same elements within the breast as a fibroadenoma. Some
Hmm.
people believe that it is a spectrum, some people believe that it is a mutation. So it is not really totally clear in terms of all the underlying etiologies, but that is one of the other things that we need to consider. So, for the most part, however, a fibroadenoma or breast mouse is a benign condition that has no risk of developing into cancer. Once these various criteria, not increasing in size, not associated with any symptomatology, not greater than 5 centimeters, and then there's no suspicion of phylloides tumor.
Great. Now you just mentioned two things: calcifications, microcalcifications, and septations. We're going to get back to that closer to the end because
Right.
this evening I know we want to really focus on benign stuff, but we're going to spend the last few minutes talking about malignant stuff, and those are the type of two of the features that we look for if we are concerned that there may be malignancy, right?
Right.
But certainly we will continue actually going into some of these other benign masses or lumps that one may appreciate in the breast. So something not quite often seen, but more so in women who have large breasts. Tell us about fat necrosis, something that we don't often see quite often, but can happen with women that have quite large breasts.
Right. So fat necrosis is really an entity which develops from some type of injury or trauma to the breast.
Right.
So a lot of times patients may hit the breast. There may be some type of ill-fitting bra even that can cause the issue. Or even sometimes persons who might have had surgery on the breast. And they can then present with fat necrosis. The issue with fat necrosis is that it can present in a similar fashion to, as always, breast cancer, because you can have an irregular mass, which may not necessarily be tender to palpation. And then this may lead actually for patients to get other imaging investigations done. So they may be imaging studies, so they may be sent for mammography, ultrasonography. Usually, a lot of the times, though, it is really difficult to distinguish fat necrosis from malignant lesions, because the fat necrosis then can look like undefined. Usually, sometimes can be described as spiculated dense mass on these imaging studies, and these are some of the usual terms that we would actually associate with breast cancer. So, really, for the physician who may be listening or for a patient, the only way that we can really rule it out per se is if we actually get a biopsy of these lesions and send it to the lab to get tested. There, however, is a treatment algorithm potentially. So if it is that the patient's history is not suggestive of breast cancer and there is a history of trauma, now there is the caveat that a lot of patients will attribute masses that they feel to, oh, I had hit the breast some time ago and then I felt this lump. And sometimes the trauma can actually be a red herring, meaning that the mass was actually there all along. They just never noticed it. And the trauma then led them to actually identifying the lesion itself. So observation is an option if there is a clearly defined history of trauma and there isn't no other suspicion. But biopsy would be one of the definitive ways that we can actually rule out whether there is any lesion within anything to worry about, any malignancy to worry about within the breast.
Okay. Now, quite often persons come and say, Doc, my breasts feel very lumpy. Right. And they feel very dense. What are they referring to? What is that?
Right. So there is an entity known as non-proliferative disease of the breast. And within that, there may be some type of cystic disease that actually may be occurring within the breast. Right. So cysts are relatively common presentation for patients coming to any breast clinic or any surgical clinic. And obviously, as I said earlier, it is a concern as to whether whether there is cancer present or not. Majority of the time, to be perfectly frank, cystic disease of the breast is usually a benign entity in the majority of patients. So usually you would see this occurring in about the 30-year to 50-year age group. And the majority of the time, it is usually a benign condition. So the usual approach, as with anything, for a patient who maybe come in and complain of lumpy breast, and you suspect that it may be actually cysts that are within the breast, would be one, obviously, to take a history and examination. And if it is that the patient is who is identifying this, because there may be a varied audience that is listening, they should obviously seek medical attention if they do feel something that is abnormal, some abnormal lumps within the breast. Even if it is that they believe that it is a normal variant for them, or that, that may be their norm, you should still seek some type of medical intervention, even if it is just for reassurance. So simple cysts, like we would say, and simple cysts from a medical standpoint, meaning that there are no septations or no divisions within the cyst itself, and there are no solid components within the cyst, those are usually benign. And you're usually going to be able to detect those on ultrasound evaluation of the breast, right? The things that would be concerning for somebody who has cystic disease is whether there may be a bloody discharge associated with the cyst, and if on the imaging, if there are septations within the cyst itself, whether there is associated solid component. So even if persons aspirate the cyst and then there's a solid component that is left, these are patients that you should probably investigate further, whether it may be with a biopsy of the solid component that is left. A lot of the times, persons may consider doing cytology and sending the fluid if there is an associated discharge coming from the breast, but a lot of times that is not really helpful in trying to determine what may actually be happening within the breast. There are some other lesions or other conditions within the breast that can, as you had outlined, give patients a lumpy feel, as you have put it, to the breast, and these then may go on to be your proliferative disorders of the breast. So you may have some proliferation of some of the elements within the breast, either within the around the nipple areola complex or within the actual breast itself. So there may be some conditions which may be hyperplasia, which is just increasing size of the increasing size in the number, of the breast units. And this may be either atypical or typical. The issue that would be more concerning is when you have atypical hyperplasia within the breast itself, right? Whether this may be either from the ductal or the lobular units, but that may be getting a little bit too far down into the weeds.
Well, I'm going to pause you right here now because I see that we have a question that is sort of asking, going along that line, is a type of breast tissue more prone to breast cancer than other types of breast tissues?
Okay, so there are different elements within the breast, and you can have, there's a lobular unit, there's ductal unit. In general, there's epithelial lining of these different units, and this is where breast cancer, as we know it, will actually arise from. And so from either of these, once there's epithelial tissue, you can get breast cancer arising. So there, on a broad sense, there are two types of breast cancer. So you can have ductal carcinoma and lobular carcinoma, just in general terms. There are different histologic breakdowns as well. There are other conditions in the breast that are not breast cancer, as we would describe it, as arising from the epithelial elements within the breast. But like I had described earlier, the phylloides tumor, which are fibroepithelial tumors, meaning that they can arise from both the stroma and the epithelial elements within. So the connective tissue within the breast itself, right?
So essentially,
So
like
to answer
the more of the support mechanism
the
within the breast.
support mechanism within the
Right.
breast. So breast cancer can arise in these major tissues, um, if that answers the question.
Yes, I think it does. Maybe we can get some feedback from that listener. I have another question here. Good evening. If the breast is usually fibrous, but the left breast saw a mass at the mammogram and had to get an ultrasound, and the ultrasound showed cysts in both breasts. However, the right breast showed an abnormality. The doctor suggested waiting for a period to re-ultrasound the breast. Should I wait or should I get a biopsy for that breast, although it didn't show anything on mammogram?
All right. So there are a couple issues there to parse out. So, as with anything, and this is with all medicine, we usually take a detailed history and a clinical examination. So, just based on the information that is presented, it would be difficult to give a definitive answer, but I'll just try to work through some of the things that were outlined and just highlight some of the problems or some of the thinking going behind the different management options. So obviously, if this is a person who has a significant family history of breast cancer, that puts you at a increased risk category, depending on who it is in your family that might have had breast cancer. So if
Right.
it is a first degree relative, a mother or sister who might have had breast cancer, then that is somebody that we're going to be looking closer to try to pick up on something in the early phases. Um, it said that the breasts are usually fibrous, so it then depends on if there is a known underlying condition within the breast, and this is where the breast awareness comes into play, and whether they might have sought medical attention before for this fibrous nature of the breast, so that the clinician who is seeing them actually also has an idea as to what their breast would normally feel like. So that plays a role um, as well in the evaluation. Now, anybody that has a mass, and we would have gone through some of the different differentials that we have for a mass. But in general, for us, and the person didn't say their age or anything like that, if someone presents with a mass in the breast, the usual step that we would take would be to biopsy the mass. There are different caveats and stuff like that that go with that, but the usual practice would be to biopsy a mass, and especially a new mass that is identified. The imaging that is done afterwards are just adjuncts to that. But for us, from a surgical standpoint, for us, a lot of the times to make a diagnosis, what we want to do is to get tissue to the lab, look under the microscope, and help us to identify what may be the underlying pathology.
Right.
Now, like I said, there are caveats to that. If it is a younger person, the risk of breast cancer is low. If clinically you think there may be something like a breast mouse, then that may not be necessary. But in general, that is the what we would like to do first. A lot of the times, though, patients may actually present to the clinic with a mammogram already done. And again, there are different caveats to that. Because if you're having a mammogram done, and persons would normally do a mammogram as because they think it is part of screening. But technically, if you already have a pathology within the breast, that is not a screening mammography, because you're then trying to identify whether there is any pathology. Well, you know that there's a pathology, but you're trying to help the imaging to define whether what the pathology may be, and if there are any other abnormalities within the breast itself. And mammography has some of its benefits and drawbacks, and it also depends on the age of this patient. Like I said, that is not stated. So, depending on the density of the breast, mammography may not be the best investigation to investigate the breast mass. For younger persons, ultrasound may actually be the investigation of choice because of the density of the breast tissue itself. Mammography may not be able to penetrate through the breast, so that you may not be able to identify certain pathologies. So ultrasound may be one of the actual better modalities to use in the younger population.
And also, it could be quite painful.
Painful as well. That's I think one of the major complaints that patients have in terms of having mammography done, because there has to be some compression applied to the breast, and that can be very, very uncomfortable.
Great.
Now, another part of the evaluation would be that once either of these imaging investigations are done, the radiologist then makes an assessment of the lesion that is seen, and based on certain descriptions or what they see under the imaging, they then use a grading system, which we call BI-RADS, to then give a grading of the pathology that they identify. And this pathology ranges from no diagnostic abnormality to malignant disease, right? And it may be based on those recommendations that the patient was actually told that they should have imaging repeated within 6 months. It sounds like that may actually be what is happening there for this person.
Okay. I wanted to go on because you mentioned a little earlier about um, discharge, different colors of discharges coming from the breast. And you spoke about a bloody discharge, which brings me to ductectasia, which
Right.
is more, we tend to see more the female who has gone through menopause or is perimenopausal, as we would call it, or around the time of menopause. Can you tell us a bit more about that and why it happens, really?
Right. So ductectasia, it usually affects the ducts around what we call the nipple areola complex. So like the nipple and the surrounding darker tissue
Right,
around the nipple itself. Right?
right,
And it's usually a non-specific dilation of one or more of these ducts, and it's usually about 2 millimeters in diameter, but that's not anything too significant. Basically, it's just dilation of the ducts underneath the nipple areola complex, and then this can lead to um, discharge, as you described.
right.
So the duct is usually filled with fluid or cellular debris, and then sometimes this can even having calcifications, which can then show up on some imaging studies, right?
Right.
And it's usually associated with some type of periductal inflammation, some inflammatory process.
So is it really something for the patient to be overly concerned about, especially if they're seeing this sort of rusty color or bloody discharge coming from the breast?
So a lot of the times, no.
Right.
It is usually a benign process. There is, as with anything, there's a small percentage that may have some malignant disease, but
Right.
that is something then that you will need to see a medical practitioner for. So if there's an associated mass that you may see within the lump itself, um, then that may be something that might need further evaluation. But in general, and for all of the different conditions that can actually cause nipple discharge is not one of the more common presentations of breast cancer. So some patients face. It's not usually one of the more common presentations of breast cancer.
Okay, I want to switch gears here a bit. You earlier mentioned the importance of a family history. And I think it's really important that we really move away from getting to know, or rather, move away from not knowing about our family's history to really having these discussions within our families about pathologies that your family may have had or your family currently has, so that
Right.
you can actually help yourself potentially in looking out for that pathology down the road if there is a hereditary link. in terms of the actual person presenting at a later date. So I wanted to
Right.
go into some of those genes that we often hear about being counted around in the news, like for instance, the BRCA1 and BRCA2 genes.
Right.
We have seen persons, celebrities, even like Angelina Jolie, who went as far as to have a double mastectomy as a result of the fact that she actually had positivity for such. So let's talk about that. Tell us about these genes.
Right. So, as you would have said, some of these things are now coming into light more because there is a lot more research going into breast cancer. And I think breast cancer is one of the most highly studied cancers that we have out there. So, one of the genes that has been identified as an increased risk factor for persons to contract breast cancer is the BRCA1 and the BRCA2 gene. So it can become a bit confusing for patients when they hear about these different conditions and want to know, well, do I have it? Should I get tested? And it can cause some anxiety
Right.
among persons when they actually think and sit and think about these conditions. So, in terms of the genetics of breast cancer, it is really a subset of patients who will get breast cancer who are at increased risk of getting breast cancer that would have the BRCA1 and BRCA2 genes, right? So there are some things that we would use, or clinicians, geneticists would use to try to identify persons who may be at increased risk of having these inherited genes. And some of the things that we look at is so early age of onset of breast cancer, whether there is an increased prevalence of bilateral breast cancer within the family. There's an association with ovarian cancer as well. And
Right.
also for those persons who may actually have male breast cancer, and um, those persons who may have triple negative disease. We haven't gone into breast cancers yet, but triple negative disease refers to those breast cancers. So, breast cancers may have some hormonal component to them, and there are three hormones that we usually test for any breast cancer. There is the estrogen receptor, progesterone receptor, and the HER2 neuroreceptor. And if you do not express any of these receptors, that is what is deemed as triple negative breast cancer. So, for those persons who are worried about whether they may have a BRCA gene within their family, these are some of the things we look to try to weed out, because it is not everybody in the general population that is actually going to be carrying these genes. So there are other malignancies that are associated with these genes. So I spoke about ovarian cancer. So specifically for BRCA1, other associated cancers that may arise are, like I said, ovarian and fallopian tube cancers, and then also primary peritoneal malignancies. So cancers of the lining of the abdominal cavity on the inside. And then in terms of the BRCA2 gene, you would have other cancers such as cancers of the pancreas, melanomas, which is a type of skin cancer, and then also prostate cancer. So from the breakdown that I would have discussed, and from jumping off from what you said in terms of patients knowing their family history, because sometimes it can be very frustrating when you ask and you're taking a history and you're asking the patient if anybody else in their family has a history of cancer. They will tell you, yes, I think my dad had some type of cancer. But what did he have? I'm not sure. So that then really hampers our risk stratification when
Right.
we're trying to identify those patients that might be at an increased risk. So there is prostate cancer that can be an issue. There can be, like like I said, peritoneal, pancreatic, even some. There is even an entity where you can have gastric cancer associated with increased risk of breast cancer as well. Right. So that is a general overview of how we look at BRCA1 and BRCA2 to try to determine who actually may be at increased risk of having these genes.
And I'm very glad that you actually mentioned that it is important to know the type of cancer if a family member does have it, because there's also been a well documented incidents of there being a link between breast cancer and thyroid cancer, and certainly it is not just confined to, and it's an easy and okay to say, well, I think a family member had cancer, full stop, not sure which one it is. But really, it's important to have that conversation with your family members to actually know what type of cancer it was, and so that we can screen you earlier,
Right.
and potentially prevent a negative outcome, because we can detect it a lot earlier in its presentation. So because we have approximately 15 minutes left in our show, I want to now go into talking about breast cancer proper, and also, as I truly promised the males that are in the group, about the importance of why men should actually evaluate their breasts. Let's start with why men should evaluate their breasts, and then speak about breast cancer.
Right. So it may not be a well known fact, but it should be that men are susceptible to getting breast cancer as well. Mind you, it is not common, but it is something that can occur. And because it is not something that is actually thought of, some persons may present at a later stage um, than um, a female who may actually be consider that they actually are susceptible to this type of condition. So it's for two reasons. One, that they may present later because they're not thinking about it, and two, like I said, that is actually one of the risk factors that we look at in trying to determine whether persons may actually have one of these inherited genetic risk factors or genes that predispose you to having breast cancer. So, as with females, there is a risk of breast cancer in males. Males will normally, though, present for to the surgical clinic with complaints of gynecomastia, which is just enlargement of the breast, and this is either bilateral or unilateral. um, it may be due to different hormonal factors, it may be due to medications that they're taking. So it does, and it can cause some anxiety among men. But breast cancer will be the major thing that we would need men to consider um, when they're actually presenting with any pathology within the breast itself. So
Right.
there's less breast tissue generally for men, and it may actually be more striking for you to see um, changes within the breast sooner potentially if you're actually looking at the breast or the chest wall.
Great. Um, in terms of breast cancer now, what
Mhm.
are, you mentioned two of the things that we as doctors we look out for on imaging. But what are some of those concerning things? And I just want you to go over, because I see a question here in the chat. Could an inverted nipple lead to any problems with cancer? And I think you already mentioned. So just for the benefit of the listeners, just talk
Mhm.
about those things when we actually do an examination that would cause us to raise a red flag, or say,
Causes,
"Hey,
right?
we need to
Causes for
investigate."
concern,
Absolutely, we need to investigate this a bit further.
right? So, firstly, whether there is any new mass that is palpable within the breast. If there is any change within the contour of the breast, so if there is any dimpling of the skin, if there is any retraction of the nipple, any change that is abnormal within the contour of the breast is something that will raise an alarm. breast pain, which a lot of patients actually present with, is not something that's usually associated with breast cancer unless it is really at an advanced stage. So it's really a mass or changes within the contour of the breast. There is an entity, and we had spoken about breast abscesses at the beginning of our talk. There is an entity called inflammatory breast cancer,
Right.
which can mimic a breast abscess. So this is one of the things that you need to consider when you're actually seeing somebody who may not be lactating and who presents with some inflammatory condition of the breast, which you suspect may be an abscess, but either on imaging or with antibiotic coverage does not necessarily resolve or improve, then you need to consider whether this may actually be an inflammatory breast cancer. And biopsy in that scenario would be something that would help to make the diagnosis. So those are some of the major things that we take into account. And this goes, as I say, hand in hand with your clinical history. So your history that you take and whether you think that they are at higher risk for developing breast cancer based on history and then clinical examination. Also, then, if there are any other swellings outside of the breast. So, typically, the breast, and how we will look at it generally, is that breast cancer will start within the elements within the breast and then it can spread to other parts of the body. So, sometimes you may get swelling into the what we will call the armpit. Bajans may say that they may feel wax and kernel, which is what we would call, the medical fraternity would call a lymph node within the armpit as well, or even if sometimes they may actually move and go to some lymph nodes within the neck as well. So
Mhm.
that is something that we would look out for.
Okay, I'm very glad that you actually mentioned that little piece because quite often on examination, a lot of persons forget to examine not just the breast proper, but also extend and go up into the armpit to make sure that we are not missing the tail of the breast and
Right.
certainly those lymph nodes. Um,
Yeah,
so,
definitely.
so you have spoken about what would cause us to probe a bit deeper. You did mention that for younger females, yes, we would examine that female investigate her, sorry, primarily with ultrasound, because generally the breast is a lot denser. And then for someone who is perimenopausal or postmenopausal, we generally tend to go for mammogram. But really, what is the workup for that patient after that ultrasound or mammogram with something that is suspicious of cancer?
All right. So the workup involves, and I said this is one of the more paramount things for us from a surgical standpoint, is a biopsy of these lesions. So if there is a mass that is actually palpable, biopsy is the number one thing that we actually would prefer to do.
Right.
The other investigations in terms of the ultrasound and the mammography, those are adjuncts, but biopsying of the mass is the major thing because we want to get that tissue under the microscope to look at it and to see what we're actually dealing with. That can help us a lot. So a lot of the times you will have general practitioners who may actually call and say, well, we have a patient here with a mass that we've been seeing for a few months and we were trying to get them a mammography or we're trying to get them an ultrasound, but the wait is too long. Do you think you can speed up the process and stuff like that? In general, we would want to see those patients from the time you actually feel a mass refer. Even if it's just a discussion with the surgeon, you should refer
Absolutely.
those patients so that we can then make a determination as in terms of their risk and then get a biopsy so that we can send it to the lab, get it tested, and then we can go from there. Because once you have that tissue and you have a diagnosis, then you know where you're going one way or the other. There is the other side that the biopsy, depending on the size of the lesion and how well the biopsy was done, may not necessarily be representative of the mass that is there, and then depending on the clinical scenario, that may then bring us to the excision
I'm losing you there, Dr.
Oh,
Doyle. You just sounded really, really far.
oh, sorry. Can you hear me better now?
Yes, please.
All right, still okay. So I was saying that um, in terms of the biopsy, it may not always be representative.
Right.
And in certain scenarios, instead of just taking a little piece of the tissue, if we need more information and our clinical suspicion is high, we may actually have to do a full excision of the lesion, depending on the size, or take a bigger tissue in the operating theater so that we can get a definitive diagnosis. So
Right.
for me, the ultrasound and the mammography are adjuncts in the workup, but once you feel a mass within the breast that is new and abnormal, then you should refer those patients to the surgeon
And get that biopsy done.
and get the biopsy done.
And it's important that you do that early because if we can catch it early, breast cancer can be cured, depending upon the type it is. Yes. And the
Right.
stage that
Yeah.
we get it at.
And the stage that we get it at. Right.
Right. So it's quite important not to delay to have your workup. And it's not a matter of trying to send panic through everyone who may have a mass now to turn up at the Queen Elizabeth Hospital
Right.
to be biopsied. But certainly to not sit back and wait and say, well, I'll wait and see if in 6 months it's still there. And then you have some sort of advanced pathology. But certainly at least have some medical practitioner look at it and then advise you appropriately.
Right.
Um,
Because it's really based on your risk that we're going
abs-
to then make our determination.
Absolutely. And quickly, when you spoke about the speculations and the calcifications, and I know that probably persons are now glued trying to say, what is this about speculation and class and calcifications? Can you please explain those here quickly to us before we have to wrap up?
Right. So those are some descriptions of lesions that you may actually see on different types of imaging, mostly mammography.
Right.
There is the entity of breast MRI, but I don't think that is available here on the island. Um, I don't know if things might have changed recently, but I don't think it's available on the island. But in terms of speculation, so that's just like a star-like appearance of a mass on imaging that may more be associated with malignant conditions. And then there are calcifications that may actually show up on imaging. And there can be a variety of different causes of calcifications. And this can then just lead to persons requiring further investigation in terms of a biopsy of these lesions. This is not really something that the general public, because you can imagine that persons may get a bit worried and start reading
Absolutely.
the mammography reports and stuff like that, looking for these different terms. This is something that the radiologist who is trained to look at these investigations, these are some of the things and some of the characteristics that they look at on the imaging to try to determine whether a lesion is malignant, meaning cancerous, or benign, not cancerous. So it's nothing that patients in general need to worry about too much. And it's just something for the radiologists and then the surgeons and general practitioners look at to try to determine their risk of having a malignant condition.
In terms of trying to work up that patient
Work
appropriately.
out the patient, yes.
Great. Excellent. So, in our last 2 minutes, Dr. Doyle, you did a fabulous job of taking us through breast pathology on a whole, both benign and malignant, both in male and female. Are there any take home points you want to leave with us this evening?
My major take home point is don't be afraid to seek medical conditions, to
To
seek
seek
medical
medical help.
attention.
All right.
One of the more heartbreaking things is when patients present with advanced disease, especially of the breast, because they were afraid of the diagnosis
Or sometimes
or what they
embarrassed.
just saw, or embarrassed. I think we're here to help. Breast cancer is one of the more treatable, if not even
Mhm.
curable, conditions that we have out there, depending on the stage which it is caught. That, along with colon cancer, I think is one of the other things that we should put an emphasis on in terms of screening and prevention.
Absolutely.
And there are a myriad of modalities that we can use to treat breast cancer. So just having a diagnosis of breast cancer is not a death sentence. There are persons that have been cured, and there are persons that are living fruitful lives after having been treated for breast cancer. So my take-home message would be, don't be afraid, seek medical attention. We are here to help, and there are many options available.
And is there any particular time they should start screening, even if they don't have any signs?
So in general, if you have a regular risk, not an increased risk, you would say about 40, you should start screening. But in general, as we had started our conversation, you should be breast aware.
Good.
And that can
Excellent.
start from the time you start to develop breast, so that you know your breast.
Excellent. Thank you so much, Dr. Doyle, for coming out this evening and really taking off a lot of the misconceptions and misunderstandings that persons have around breast pathology. And I want to say thanks also to our listeners who came out this evening and asked their various questions. Once again, I encourage you to join us and follow us on both Podbean and Anchor. Until next week on First Aid Chats by Dr. G, closing the gap. Good evening, Dr. Doyle.
All right, good evening. Thank you.
Mm-hmm.